This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Matt Barrett from Virginia Commonwealth University in Richmond, Virginia. Today I'm interviewing Julie Schneider and Sonal Agrawal from Rush University in Chicago. We're discussing their paper titled Effects of Cerebrovascular and Lewy Body Pathology on Parkinsonian Signs in Community-Dwelling Older Adults. In this study, Julie and Sonal and colleagues analyzed a large cohort of 1,753 community-dwelling older persons with clinical and autopsy data to investigate whether Lewy body pathology and cerebrovascular disease act synergistically in their relationship with Parkinsonism in older adults. Thank you both for agreeing to talk with us today about your publication.
Thank you for having us.
So just yesterday in clinic, I saw a new patient who was older than 90 and had mild symmetric Parkinsonism on exam with prominent gait impairment and also some mild cognitive issues. As referenced in your paper, this is quite a common clinical presentation we encounter in neurology. Mild Parkinsonism is present in 50% of older adults over 85 years of age. Just before we get to the results of your study, tell me what we knew about this large group of older adults who have mild Parkinsonism before you started.
The mild Parkinsonism that we see with aging is not a benign condition. So we know that people get older and they slow down and they're less steady and they might be a little bit rigid or have a tremor. And we just accept, well, that's, quote, normal aging. But if you look at the epidemiologic studies, we and others have repeatedly shown that having these signs and symptoms are actually increase your risk of significant morbidity and mortality, as well as your risk of developing cognitive impairment. So there's been a lot of interest in public health and the epidemiologic studies to look at what's the underlying cause, like what is happening as we get older that's causing these Parkinsonian-like symptoms in aging.
So with that background about the current state of the field around mild Parkinsonism, tell us what you found in this paper. What were the major findings of the study?
So this paper, we specifically examine the impact of Lewy bodies and cerebrovascular pathologies on Parkinsonism. And we found that Lewy bodies as cerebrovascular pathologies like macroscopic infarcts, atherosclerosis, and arteriolosclerosis are associated with increased risk of Parkinsonism. And we see that cerebrovascular pathologies, especially atherosclerosis, has greater impact on Parkinsonism, followed by Lewy body pathology. In addition, we also examine the synergistic link, whether these two pathology have synergistic link to potentiate the severity of Parkinsonism. And we found that cerebrovascular pathology and Lewy bodies synergistically interacted to increase the severity of Parkinsonism. Means if the person have both pathology, they have more likely to have Parkinsonism than the person who have either one pathology.
Just to recap a couple of those points, cerebrovascular pathology is a risk factor for mild Parkinsonism, and it appears that atherosclerosis is especially a risk. And then Lewy body pathology is, of course, a risk. And then it's that the two of those together can act synergistically to increase someone's risk even further, is what this paper has really added to the prior literature. Now I want to discuss your findings as they might relate to possible public health implications. I know we're going beyond the paper here, but I think it's important to think about this. So at least for now, we don't have any prevention strategies or treatments for Lewy body pathology, but there are some potential prevention strategies that could be tested for cerebrovascular risk factors in cerebrovascular disease. In your study, you looked at different types of cerebrovascular disease. Which types did you find interacted with Lewy body disease, especially to increase these Parkinsonian signs? And we can postulate about what ways we might intervene to prevent someone's risk of developing mild Parkinsonism.
We found that the two that are synergistic with Lewy bodies are atherosclerosis, and we look at atherosclerosis at the Circle of Willis, do a semi-quantitative assessment of the circle. The other thing that we found was associated with synergy was macroscopic infarcts. So macroscopic infarcts, anything we can see by the naked eye. I should point out that it's not just someone who's had a stroke. It's basically anything that we see on the gross brain. So this would be synonymous with what you would see on an MRI. And we see in our cohort around a third of our older people who die around the age of 90, around a third of them have macroscopic infarcts. Some of them are quite tiny, but we see it in a substantial number of people. So the two main things that we saw that had synergy was atherosclerosis and macroscopic infarct. Now, I should mention that small vessel disease, arteriolar sclerosis, was related also to Parkinsonism. It just didn't have a synergistic effect. It's not that small vessel disease is good for you. That also is increasing your risk of Parkinsonism. It just didn't have the synergy that these other two pathologies had. So from a public health standpoint, it really, I think, hammers home how important vascular health is. And I think we come back to that a lot when we come back to dementia, Alzheimer's disease. What's good for your heart is good for your brain. So the traditional vascular risk factors we have shown in our study increase atherosclerosis and macroscopic infarct. So, for instance, blood pressure, the average blood pressure of older people, even our average age of enrollment being in the late 70s or 80s, people who have higher blood pressure have more arteriolar sclerosis, atherosclerosis, and more infarcts. So I think this really tells us how important it is to monitor, as physicians, monitor our older people's vascular health. So someone comes into your clinic who's 70 or 80, it's not, oh, you've been doing that your whole life, just whatever, you're happy. We're obligated to tell people that, it still matters. It matters that you control your blood pressure. It matters that you eat right. It matters that, control your diabetes and weight, etc. So people want a magic pill, but really right now, the best therapy is prevention for this sort of thing. I think the other thing to me that's really interesting here is this interaction with Lewy bodies. Because when we think about Lewy body disease, we don't have a lot of Parkinson's. This wasn't a Parkinson's disease cohort. But we have a lot of Lewy bodies. So we have 25% of our cohort have a Lewy body in their brain when they die. Very few of them have the diagnosis of Parkinson's disease, right? So what's interesting about this is what this suggests even about other Parkinsonian disorders or Lewy body disorders, that vascular disease somehow is potentiating in ways that we don't understand something that's neurodegenerative. And it's just not an additive effect. It's making people even worse. So in my mind, and we certainly don't show that here, but in my mind, it also argues to the point of even in your Parkinson's disease clinic or even in your movement disorder clinic, that this vascular health is really important. It may not only prevent an age-related Parkinsonian syndrome, but who knows what it might be doing even if you have Parkinson's disease, which is really interesting when you think about exercise and how important that has been shown for Parkinson's disease.
You make an excellent point that in Parkinson's disease patients, but certainly in aging adults, it's always going to be important to counsel patients about making sure their vascular risk factors are managed appropriately. And if they're not, to make sure patients get the help they need, because it really is one of the best ways we can probably intervene to prevent some of these outcomes in late life.
I was also just going to point out, and I said this earlier, just how common mild Parkinsonism is in aging. You don't have to go very far to see older people with, there's a slow gait and slow movement and a little bit of rigidity and the falls that are happening with older people. So a little bit of prevention might actually go a long way with public health.
That's a great point. Just that, the prevalence alone would lead us to have a pretty large impact if we had any sort of intervention that prevented this Parkinsonism, prevented the vascular risks or vascular disease, really, that is contributing to the Parkinson.
I think a lot of older people want to be active as long as they can be. They want to be able to still walk to the grocery store and go out with their friends and do things. And, when they lose their mobility, that's really hard. So it's important.
Also hearing here is that I think people understand the link between vascular disease and cognition. Maybe that's a little better understood, but then the link between the reduced mobility is really maybe where people have not extended that yet.
Correct.
Now to another finding in your study. Specifically, you found that the interaction between Lewy body pathology and atherosclerosis and macroscopic infarcts were not associated with all Parkinsonian signs. They were associated with the severity of mild Parkinsonism, but not all the signs equally. What were the relationships that you found between Lewy bodies, the various cerebrovascular pathologies, and Parkinsonian signs? And what did you find when you specifically evaluated the interactions between Lewy bodies and cerebrovascular disease?
So we looked all for Parkinsonian signs: bradykinesia, rigidity, tremor, and Parkinsonian gait disturbance. It is very interesting that we see a different relationship between the pathology and different Parkinsonian signs. So we found that Lewy bodies are strongly associated with tremors and rigidities, while cerebrovascular pathologies are more related with the Parkinsonian gait. We also see that only the Parkinsonian gait were affected when these Lewy bodies and cerebrovascular pathology were together. So we see only these synergistic interactions only for Parkinsonian gaits, not for the other domains.
I think that's a really important point. If we go back to the sort of public health implications of your study, what we can intervene upon is the cerebrovascular disease, potentially, and the fact that the cerebrovascular disease is what's contributing primarily to the gait impairment. And arguably, the gait impairment is what leads to falls and some of the greater morbidity of these Parkinsonian signs. That really speaks to the cerebrovascular pathology being what we potentially would want to intervene upon to improve people's mobility later in life. I want to turn to just some of the methodology of this study. A strength of your work is that you based your findings on 1,753 older adults from 3 large community-based studies. It's quite a large group of patients and autopsy data to pull together to perform the type of investigation that you did. Tell us about these 3 cohorts, the overall characteristics of the cohort, and any study limitations that might limit generalization of your results.
This is taken from 3 cohorts. I'll describe each of them. The religious order study, which started in, I believe it was 1994, and it's been in the community since then. So over 25 years of following older nuns, priests, and brothers from across the country, and basically enrolling them without known dementia, 65 or older, to enroll. We don't kick them out if they end up having some problems with their cognition, but we ask for people who don't have dementia. And then we follow them yearly with cognitive exams as well as physical exams. We take elaborate histories of risk factors, and then we do neurologic exams, and we ask them to donate their brains when they die. So the religious order study has been going on for many years. And then the second study, we wanted to branch out into lay population because of one of the weaknesses. It's a weakness, but it's a strength of the religious order study, is that they all live together. They all have good health care. They don't move a lot. If they do move, we know where they move to. They were a good population to start with because we were able to keep following them and get good return rates. But when we wanted a little bit broader, more representative group, we started the Memory and Aging Project in 1997, which is in a lay population in the Chicagoland area, where we get a little bit broader cross-section of older people from an education and racial ethnic diversity standpoint. So the Memory and Aging Project really enabled us to generalize a little bit more what we were finding in the religious order study. But it had the same methodologies. We see them yearly. They enroll without dementia. They get neurologic exams every year. We draw blood. We do nutrition exams. We do a lot of work on our participants, and they altruistically agree to be in these studies. And Memory and Aging Project, they also agree to autopsy. And then finally, we have a minority aging research study where we are specifically interested in African Americans, and we know that they have a higher risk of dementia, not as much known, I don't think, as far as motor, but they have a higher risk of dementia. And we wanted to start doing some similar work because we were having a hard time enrolling African Americans, even in the Memory and Aging Project. So that specific study is a little bit different in that we don't require autopsy. African Americans tend to be wary of some of our research studies, as you know. So we try to build relationships, show them why it's so important that we understand what's going on, not only in white people, but people of color. So the Memory and Aging Research Study, we don't have that many African Americans yet, but we were able to look at some. So those are the 3 cohorts that it comes from. And the Memory and Aging Project, again, and Religious Order Study is the majority of them, but we are increasing our numbers in the African American population also. So the people that enroll, while we're trying to get people representative in the community, people who volunteer for research studies, let's face it, they're just not as representative as the general community of older people are going to be. So in general, I would say our cohort does tend to be a little bit healthier than your average physician's office clientele. The thing that's kind of interesting is that we don't see a lot of differences actually between the religious order study and the memory and aging project. That's why we were able to combine them, because when we look at them separately, we said, there's really no difference statistically, we can combine them. So they really are behaving the same when it comes to these clinical outcomes and the pathology that we're seeing in the brain. We're not seeing stark differences between the two cohorts. So the limitations is going to be generalizability, right? So generalizability to the general population. We have a very high autopsy rate, which makes it much more generalizable than most autopsy studies. Most of the time with autopsy studies, people tend to want to get autopsies for their loved ones when they have something bizarre happening. The average stuff going on doesn't really solicit people say, I want my mom to have an autopsy. So by asking people to go to autopsy, we're not just getting unusual cases. We're getting like the common things happening to older people. Or we're not just seeing people in a clinic who would end up in a clinic because of Parkinson's disease or significant Parkinsonism or memory problems. We're seeing people who are living in the community, otherwise healthy. Even though it's not generalizable to the population, it probably is more representative than what a clinic sample, for instance, would be of what's happening in the population. We do tend to see different things in a clinic setting, as you might expect, where you're enrolling people in a study or they're coming to your clinic because of problems. I would say those are the major limitations.
We are including the African Americans, but still in our study samples, the mostly are non-Latinos white. So we need further studies with a diverse population that can replicate this finding and give us more information.
Right. We definitely need to do more in racially and ethnically diverse persons. There's not a lot of autopsy studies that I'm aware of in Parkinson's disease. The link between the Lewy body and the vascular, I do think is an intriguing link, even when you think about Parkinson's disease and, vascular health. But so I think it opens up that also.
Can you once more share for us what your study taught us about the relationship between Lewy bodies, cerebrovascular disease, and mild Parkinsonism in older adults?
The study really drives home that vascular disease prevention is important because we have a synergistic relationship in Parkinsonism with aging in both Lewy bodies as well as vascular disease, particularly atherosclerosis, arteriolar sclerosis. So we previously reported that all these vascular pathologies as Lewy bodies are related to Parkinsonism in aging. But what this shows us is that having both the vascular and the Lewy bodies together is particularly bad as far as your risk of Parkinsonism and how bad your Parkinsonism is going to be, and particularly with gait abnormalities. We talk about vascular Parkinsonism sometimes, but it's not just the vasculature that's involved, but it's also Lewy bodies. They're both working together to cause this syndrome that we see in older people.
I'll remind listeners to please check out the full article, Effects of Cerebrovascular and Lewy Body Pathology on Parkinsonian Signs in Community-Dwelling Older Adults. That was published in the August 15th, 2023 Neurology Journal. Thank you both for joining us today.
Thank you for having us.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.